Hi, good evening, everybody, and welcome to our monthly RAMP webinar. This is our Rudasa webinars that is particularly focusing around Rural Africa Mentoring Program and looking at ways to help keep people up to date and just extend our capacities on a wide range of different topics. And it's always amazing to meet these extraordinary people that come on board and help us with all these different aspects. I really like the talk this evening. We're actually terrible at doing anything surgically or wound related. You know, all our stuff is always so infectious disease or child health or maternal health orientated. And so I'm very happy to be welcoming Dr. Helga Nauhaus, also from East London. We're both from this side of the world. And actually, Dr. Nauhaus came originally from Namibia to study medicine, and we're very happy that she stayed. And during her community service here, she found herself knowing way too little to look after her surgical patients properly, and this particularly also included wound care. So she almost gave up on medicine in this struggle, but carried on. She might tell us a bit more about that. But this time with the zeal to learn as much as she could, and she did never wanted to be in that same ill-equipped situation again. So she's wanted to share what she's learned to help others, not to feel helpless and hopeless, and equip others to look after their patients better. So currently she's a Paediatric Surgery Registrar in East London and has with a dream of specifically making burn care better. So the session is going to cover the basics of wound care with tips and tricks valuable to both adults and children. And this is a very neglected topic. It's not often taught, and it's not often taught. Quite often you have fancy reps that will come and tell you about fancy dressings, which you don't have available. And so I'm really looking forward in being able to be capacitated on things that that we can actually use in our settings. Just a reminder, please, there will be a poll at the end that helps us to keep track of attendance. If you do struggle with a poll at the end, then please just you can put your name and MP number in the chat, but the poll is the best way to keep track. I'm now going to stop sharing my screen and I'm going to hand over to Helga. Thank you.
Hello, everyone. Yes, burn care and wound care has been a big challenge over my career and is still a challenge. And as Madeleine correctly said, we often don't have what people come and bring us. Fancy reps tell us, yeah, this wonderful product is the best thing ever. And we can't afford it, or we do order it and it takes 6 months to get there, and then it's only for a specific few wounds, but the range of wounds that we see is way too big. So this is not a talk on how to apply all sorts of fancy dressings that exist. My advice would be, if you do find some, play with them, put them on different wounds and see what happens. But for that to be able to be done, we'll go through a few basics of wound care. And at the end, you're welcome to ask some questions. A disclaimer, I'm a ped surgeon, and therefore most of the pictures will include children, just because those are the pictures that I have available. All of what I say will be extrapolatable to adult care and smaller wounds, so don't be horrified when you see these are bigger wounds than what you manage generally. It is still wound care as you can apply it to wherever setting you are, to whatever size wound you're dealing with. Smaller wounds are often easier, bigger wounds get more complicated, but sometimes we don't even know where to start. So where do we start when we see all of these many wounds, ranging from dog bites to old neglected wounds to who knows what has been done, to degloving injuries, to bed sores, to burn wounds? Where do we start? What do we do? What do you think? What do you need to know to even figure out where to go next? And hopefully at the end of this talk, you'll have a better idea of what to ask and where to go from there with what is available in your setting. So, as always, we always want a basic history. Surgeons in general don't want the whole long story of where you came from and where you're going to, but basically what happened. How did the wound come about? Is it a burn? How was the child or adult burnt? Was it a hot water burn? Was it electrical injury? Was it a fire burn? Because that will give you ideas of what type of wound you're looking at and how you're going to manage it from there. I'll touch a bit more on pressure ulcers as we go through the talk, because I think that's what you see very commonly. So especially if it's over pressure point areas, is this a pressure sore? Because how you look at the wound and how you manage it differs to a wound that might have just been an old neglected wound that is now not looking so pretty. Degloving injuries you also probably see commonly, either acutely and then refer on, or you get them down referred from wherever is tired of looking after them. As well as surgical site sepsis, you often will get them down referred from surgical units saying, sorry, we run out of space, can you please deal? And then bites. Often have small entry wounds, are often deeper than what they look like. So keep that in mind. They often need relatively little wound care, but we don't usually close them initially. And the bad ones you'll probably discuss with your surgical unit anyway. But keep in mind that bites often are a lot deeper than what they look like from the outside, may or may not need debridement, but often can be washed out and managed with antibiotics. But please don't close them with stitches unless you're very sure that that's a clean wound now. So one question we need to ask ourselves when we look at the wound is, how deep is this wound? Is it within the dermis? Is it within fat? Does it go down to muscle? Do we have bone and tendon involved? Those are all important questions, because one thing we want to know is, can this wound heal by itself? Does it need debridement and sepsis management? And is it a huge surface area, or is it relatively small? Can we close it by secondary intention? Or do we have bones and tendons involved that we need to manage specially? So look at the wound and try and assess how deep is the wound. So you can see for this child, it's a burn wound. It's not that new anymore. It's a deep dermal maybe wound, but there's still a lot of dermis there. So I expect that this wound will actually heal by itself with reasonably good care, unless we have further insults to the wound. So very reasonably superficial, not that bad. Then this surgical abdomen wound, you can see there's stitches. We closed the sheath, but it developed sepsis and opened up all over again. So this involves mostly fat, doesn't go all the way down into muscle, usually because you're above the muscle, as the sutures can tell you. But is a relatively small area, which makes closing it relatively easy, even if it is quite deep. And you'll find that often in obese adults, that you'll have wound sepsis and then a long protracted course of trying to close them again. And then you may have deeper wounds. This one was an electrical injury. This was all fat exposed, and then down here is muscle, and bone is not too far away. So it's quite a deep wound, but it's also not the biggest surface area. And there's actually quite a lot of laxity of skin, so it can be pulled together. And we'll go through some of them repeatedly, so that you can get an idea of how do these wounds progress and how do we manage them. These ones are much deeper, as you can see, especially the pressure sore. We'll go through pressure sores a bit more, but this is far beyond fat. This is down to muscle, and there's probably bone involved here. So it's a very deep wound, but it's an old wound and can be managed, and I'll show you how. Then this one is also extremely deep wound with electrical burn to the leg. This is burned way deep down into the muscle, and actually from the posterior aspect of the leg, so deep through the muscle onto the bone. And then you have to ask yourself, is this still viable? Is it a wound that I can try and debride and manage like a pressure sore? Or is there actually so little tissue left that's alive? Do I just have to chop it off? And in this case, with this deep wound, we end up having to chop it off, and we have a lot smaller wound that we have to deal with. And sometimes that's the answer, is there viable tissue? Yes. Okay. How much? Okay, it's not enough. Chop it, and your wound becomes a lot smaller, but it does lead to disability. But a non-healing wound is also a disability. So then you can get deep wounds like this one here. It's a lower leg, long chronic wound with osteomyelitis, as you can see, green pseudomonas on there, slough is on there. Some has healed by secondary intention somewhat. There's granulation tissue that wants to cover this, but it's actually yucky and disgusting and struggling to close. There are two options for a kind of wound like this. One is to treat it similar as to the previous electrical burn one, that we say, sorry, this is non-viable, the bone is horrible, dead, can't fix it, and might be better off amputating. Or if we have enough skills or are brave enough to use, it can be debrided, the bone can be debrided, we manage the wound and get it to granulate, and then eventually skin grafted. It will not close otherwise. The defect is too big. There's not enough skin on the sides that can pull together to actually close this as a secondary wound closure. But that it gives you an idea that, can I manage this wound, or should I be better off amputating? And in a limb, that is sometimes the easy option is to amputate, get rid of the wound, the pain is gone, and the patients might be very much happier. Sometimes cutting off the leg is so disabling that they say, I'd rather deal with the wound, but at least I can walk around without any problems, or relatively no problems. So discuss that with your patient and see how you can manage that. And then you get wounds like this child who was involved in a PVA with this ugly degloving injury. This is a new injury. It's not as old as this one, but it looks in many ways very similar, deep, disgusting, horrible. There's bone exposed here. There's eye involved here. It's deep, dirty. It goes all the way into the oral cavity. And you're like, okay, is this even fixable? And it's easy in a leg. We can cut a leg off, but unfortunately we can't cut a face off. So then we have to change the approach slightly and say, can we debride this and close this somehow? Can we bring edges together? Can we manage this and eventually get to somewhere that is reasonably cosmetically viable? Or is it possible to reconstruct it? In a complex wound like this face, you'll probably not manage in the periphery unless you have quite a bit of surgical skills and a bit of anesthetic skills, but sometimes you're required, and sometimes you just have to take scissors and a lot of water and a lot of soap and wash this out until it's clean and healthy, and then see if you can pull things back together where they think they should be going. I wouldn't recommend you trying to debride an eye and figure out what's going on there, but some of them are not quite as bad. It's involving the skull, less so the face, and they might be able to be managed in a peripheral hospital. Debriding them, cleaning them, meticulous wound care, and you have amazing outcomes. And I'll show you for this girl specific what we did, and then how her wound actually did, and how good wound care can get you a far way. The next question we ask, how old is the wound? Because that also changes what we do for it. So this child is a burn wound, happened today, is a superficial partial wound. We clean it properly with soap, put a dressing over whichever we have, and hopefully heals. Doesn't necessarily need antibiotics unless the child is systemically septic. If it's a smaller surface area, you can manage in the periphery, and we'll go through some of the details of how you manage that. And this girl is also an acute wound, but it's deep and it's dirty, and it needs a lot more attention than just a quick wash and a dressing, as we've already discussed. Then you get these pressure sores. They're usually older, a few weeks old, because nobody comes with an acute pressure sore. They only come when it's horribly and disgusting, because what most people underestimate for pressure wound is that a lot of the damage is far deeper than what it looks like on the skin. So these people come once the wound smells bad. You can see is all this fat that's dead and wanting to liquefy and slough off. And there's a lot more sepsis involved here. So it takes a bit more debriding. All of that fraught, yucky stuff needs to come off. And you actually have to ask yourself, why do we have a pressure wound here? Is there sensation in the area? Is there no sensation in the area? One, dead stuff doesn't feel anything. But if they're paraplegic and they can't feel anything, it might actually be feasible to debride this in the ward, either with painkillers on board or without. Take a normal, ordinary blade or scissors and try and get rid of as much of the dead stuff that is there, because that would help you to manage the wound and get it clean and to eventually close. And so, yeah, more effort to get this one clean. It will take a lot longer to clean it because it's already a chronic wound. You're already dealing with sepsis in there. Makes it a long course. So off the bat, you know, this is not going to be as quick and easy as a burn that just happened today and a superficial partial. But then you also get these super old chronic wounds, and I'm sure you see quite a lot of them, especially in adults. In peds, especially where there's decent burn services, you should never see a wound like this. But this child was burned, then refused surgery, and was managed with dressings for a year before they came to us. So you can see a lot of it has healed by secondary intention, trying to slowly epithelialize from the outside in. But there's bugs in here, and they eventually form an empire. So it's not just one bug, it's a whole zoo of them that grow together, become friends, and then form an empire. And to protect themselves from anything from the outside, they form this biofilm over that entire empire. If you have a wound that's been open for 3-4 weeks and looks this granulated, slimy wound that even if you scrub over it doesn't bleed anymore, you probably have thick biofilm, a lot of bugs in there, and it needs a lot different care than this one would, in that you actually have to get under that biofilm again for any dressing to make any difference, for any soap to make any difference. So often these wounds require a real proper scrub to try and get that biofilm off. Sometimes it takes excision to get the biofilm off. Sometimes we can get away with either a molten soak to try and break some of it down, or if we fancy, we can use Prontazan or the hypochlorous acid solutions. They're essentially very similar to molten, and molten is what most hospitals have. So take a diluted molten solution, let it soak for 10-15 minutes before you put a dressing or any other soap wash over it. And if you do that regularly, you might actually be able to get through that thick biofilm and then get the edges of the wound to start slowly closing again. But essentially, this wound will not heal on its own and will need skin grafting to actually close. So now that we know some of acute wounds, chronic wounds, necrotic stuff, debride things that are dirty, how do we actually treat those things? So there's a few things to manage at every wound, whatever you look at. One thing, no wound is ever sterile. Don't let anybody fool you. If you cannot grow a bug on it, you either have so thick biofilm as this previous wound was, or you stuck it into formalin to send it as a tissue MCNS, or you didn't do a good enough job. But no wound is sterile. So we never try and get a wound sterile with antibiotics or whatsoever, but we want to limit the amount of bugs that are on there. If the patient is not systemically septic, they don't need antibiotics. We just manage it with good antiseptic soap. Hibiscrub is commonly available, or betadine soap if that is available in your hospital. Please, please, please don't confuse that with foam bath. In Eastern Cape, they have tried to smuggle in foam bath as proper antiseptic soap. That obviously doesn't work. I found that out the hard way because my burn grafts wouldn't take and the wounds looked like I'd never washed them, but I had washed them. And so then I investigated what is in these bottles that they say is antiseptic soap. And I found foam bath. Some were rose scented, some were cinnamon something scented, and we made sure that they get rid of them very quickly. So please check what soap you are using and that it is actually actual proper soap. Going back one step, please, please, please manage the pain. To debride a wound, to do a dressing is painful. And I can't deal with this kid that screams blue murder because I want to touch their wound. There are a lot of things available. Ketamine is my favorite drug because it can be given safely in many settings, in many routes. Ketamine can be given oral. The only problem with oral is that you need to have the patient starved with an empty stomach, and they get so-called tachyphylaxis quite quickly. So you have to give more and more and more ketamine. Starting dose is 5 milligrams per kg, and you give as much as needed. IMI is what we commonly use because it doesn't take 30 minutes to start kicking in as the oral one does. It only takes 5 minutes. You can give it safely to anyone. They don't lose airway. They have a lot of secretions. Don't get scared. They can manage them. They can usually swallow them anyway. They don't drop their SATs. They get tachycardic, but they actually don't drop their blood pressures. So it's quite safe to give even in children and small children because you don't need to have them intubated and monitored all too closely. The last option for ketamine is to give it IV, is 1 milligram per kg for most dressings. It burns if you give it into a peripheral line, so most patients hate it for that, but it has very quick onset. It takes 10 seconds, 15 seconds to kick in. So if you do give IV ketamine, make sure that you have everything ready because the moment you give it, it's working and you don't have time to run around and get more stuff. Takes about 10-15 minutes for it to start wearing off again, so you have to be quite fast. And then the bigger burns dressing, so if you need to do a debridement or if it's a longer procedure, the IV ketamine, you either need someone there to top it up or it's actually not that feasible, and therefore we often use IMI ketamine. It gives us an hour, hour and a half to do a proper dressing, but it takes 2 hours, 2.5 hours to wear off and for them to wake up again. Another problem with IV ketamine, you need to know about, but you don't have to be scared about it. If you initially give it for the first minute or so, they will hypoventilate and drop the SATs to the low 80s. By the time you see that, and by the time you get the oxygen mask and unwrap it and connect it to the oxygen and open it and secure it on the face, their SATs are back to 95. So don't stress too much about it. I prefer the IMI ketamine because I don't have to put up in a screaming child that's already wriggly and difficult. I can just dart them with ketamine. It's 5 milligrams per kg. You can give it to adults too, but remember that they take 2.5, 3 hours to wake up, which is annoying in an outpatient setting because you need to park them somewhere and wait for them to wake up. And for them, it gets difficult to manage them with proper analgesia, but if they really cannot tolerate, they might need inpatient care and then give ketamine and make their stay a lot easier. Chronic pain after wounds is horrendous and leaves them often disabled with neuropathic pain, and that's very difficult to manage. So manage the acute pain well, and the dressing change becomes less torturous for nursing staff and doctors and patients. So once the kid or adult is sedated, adequately analgesed, we just take normal antiseptic soap, Hebe scrub or betadine or whatever is available, and gauze whatever is available and scrub the child and the wound properly. The description to that is erase the child off the table. So it's quite a vigorous scrub, wash firmly, and a lot of the bugs will come off just in that, and then it's not so well done. We get rid of a lot of bugs, and then it's not that important to have a fancy antiseptic dressing on the wound. Most of us know Gelonet. If the wound's wash is done properly, Gelonet is adequate. However, if the wound is quite contaminated, Gelonate is just paraffin gauze. So Vaseline is good enough for the wound. Gelonate is good enough for the wound. If you have fancier stuff available, use the fancier stuff, because it will also get rid of the bugs while you have the with that. There are a lot of dressings on the market, and different provinces and different hospitals have different things on tender. I suggest you get the tender document, the RT42, which has a lot of dressings on there for your hospital, and find out what you can order. Even if you have that document, you still don't get what you always want. Gelonate is generally available. If you have back to grass or something with silver in it, preferable. And if you have some of the fancier stuff available, use it. Then for all wounds, we have to manage the exudate. Some wounds are extremely wet, or you, like that pressure sore septic one, is liquefying. That exudate needs to be managed. So the secondary dressing that you put on top of the primary Gelonate or back to grass or Acticoat or whatever you got, you need something that can absorb fluid. Gauze is the most common one. If that's all you have, it's all you have. Thalbund or ortho wool is another commonly used one. It's not my favorite, but it's commonly available. Otherwise, Draw-Tex, and there's a whole bunch of them that are quite absorptive dressings. Some wounds where there's tendons exposed, bones exposed, they need to be kept a lot more moist. So then we add intrasite gel or something that's more liquid. Aquacel, you can liquid or add water to it and it gels, and it can also keep tendons and bones alive if they're exposed. So check the wound, is it wet or is it dry, and manage whether you want it slightly more dry or slightly more wet, depending on what you're looking at, which is why we went through what wound are you looking at and how deep is it and what is exposed. And then manage the cause. So in many cases, not that difficult. You have a burn, it's gone. The intra-abdominal sepsis that led to surgical site sepsis, sometimes just opening the stitches, cleaning out the wound is good enough. But if there's a fistula from deeper in and you cannot get rid of the wound sepsis, you might have a problem deeper in the abdomen or deeper into the wound. You find the same with chronic osteomyelitis, that the sepsis is deep inside and you have fistulae coming out, and that is giving you the wound that doesn't want to heal, that keeps having exudate. If it doesn't want to go away, look for deeper causes that might be the reason why this wound doesn't close. So osteomyelitis is one of them. Deep-seated abdominal sepsis is one of them. And then pressure sores is one that you have to manage the cause. If pressure caused the wound, get the patient off that area. So manage the pressure, turn them, put them into different positions so that that wound can heal. If they still lie in the same position, the wound will never heal. And sometimes there's a foreign body in the wound. It can be sutures, it can be leftover sand from a degloving injury, it can be splinters, it can be glass pieces. If those foreign bodies are in there, they need to come out, otherwise the wound will never close. And then when you look at the wound, do they need theater? Can you do that by yourself, or do they need to go somewhere else? So just a few more practical examples to put hands on to this so that you can see how it works. Sorry about this. So this child, burn wound, is not the newest one, so it's a few days old. You can see there's a little bit of thin exudative so-called slough, but it's actually just exudate on the wound. It's still superficial partial, and we expect it to heal. A few days later, this is what the wound looks like. So it now has this thicker slough. Wait, before I get to here, this wound, you can either put Gelonate on there. We fancy enough, so we have Sorbact. I've dressed it with Sorbact. Sometimes we only have Acticoat available. You can also put that on. Next time we opened the wound, this is how it looked like. There's a lot thicker slough on there. Now, what do we do? So good sedation. You can see this child is always sedated on the pictures. And Hebe scrub, you can use gauze, you can use cut up bandages if they're rough enough, and then scrub this child to try and get rid of all of that exudative slough that wants to be on there. If it's relatively soft, it will come off, and that will get rid of a load of bacteria, and you dress it again with what you have available. Gelonet, you can use Sorbact again, you can use Acticoat again, whatever you have available. For this child in particular, another week later, it looks a lot better. There's no more of this slough around. The edges of the wound have healed, but there's still all of this open area. Still not systemically septic, so we didn't give any antibiotics. We just continued with washing regularly, changing dressings regularly, and sometimes you have to change the type of dressing to manage the bugs that are on there. And another 2 weeks later, this is how the wound looked like. Just about healed. We have tiny bits and pieces open, and we were good enough to send this child home. Unfortunately, this one scratched and introduced sepsis again to the wounds and came back, and we ended up having to actually graft this area because of infection again and not managing the wounds adequate enough at the clinic that we sent them to. At this level, we thought the wound was good enough to go to a clinic and just get reasonably washed and dressed, and it should be good enough. It's not enough if the child is scratching and putting Staph aureus into the wound. Then this child, as promised, will come back to her. She was involved in a PVA with this ugly degloving injury. There is no way you can manage this with just soap and dressings in the ward. So we took it to theater. We debrided all of this brown stuff, dead skin, dead muscle, dead fat, washed out all the sand deep into the socket of the eye, and then reconstructed her, put the pieces back together where they should be, reconstruct the muscle. But in theater, because she's well sedated, we can wash it properly. I washed it twice with Hibitane soap to get all of the bugs, all of the infection out, and then closed it in layers. And that was her wound a week later. We had opened it once before this one, but you can see it's closing. It's a lot better. Her face is actually put together. This one up here, we also then just scrubbed it off, and that actually healed by itself on secondary intention. If you leave a sloughy area like this, the normal way the body deals with it is to liquefy it, and it will eventually come off. If it's too deep and there's no skin left, it will have to close with secondary intention from the outside. Like these corners will have to. You leave a little bit more scarring, but there was still a little bit of dermis left for her. So all of this actually closed without much scarring in the end. And now she has mostly this zigzag scar on her face, but fully functional and a very happy kid. So coming to pressure source, I will remind you every time, take the pressure off. Otherwise, nothing you will do will make a difference. Again, this patient with this ugly, sloughy, dead, yucky wound, this all needs to be cut off. Take scissors, take a blade, get rid of it, debride all the way deep. As much as dead needs to come off. And then it's difficult to manage because urine and poo are still very close and they need to be moved off it. Most of us in surgical units don't have enough time to take them to theater and do all sorts of things. So if you can put a catheter in, sometimes that just gives you more drama, so then you just have to deal with it. Sometimes it's actually not that bad, that you haven't diverted everything, therefore you can't package this wound up so nicely and dress it, but you're left with only a nappy, and it's a perfect bum-shaped thing to cover a bum with. And you can put betadine ointment or flamazine into this, make it a bit more wet, so all of this can slough off and become clean. And it will then eventually look something like this. You can see that this went deep into these areas. and that's normal for a pressure sore. It's a horribly deep wound because the wound started from the inside to the outside. And so if you don't take the pressure off, that process on the inside will continue and you'll never win with that wound. But if looked well after, so again, analgesia, wash it properly, regularly, once daily if you have to, take a catheter or a feeding tube and irrigate deep into the crevices of all of this wound, and then manage it with the antiseptic dressing. Because it's the perineum and because they get dirty easily, I don't waste fancy dressings on these areas. You have to manage the poo and the urine that's in there anyway. So the more frequently the nappy gets changed, whether it's an adult or a child, the better for the wound, and you just manage it with something that's reasonably easily available and relatively cheap. So you can manage it with just betadine sitz baths and then Gelonet dressing to cover it in between, or betadine dressing and change it 2-3 times a day if you have to. And if you do that well, eventually the wound will granulate, will close, will scar up, and will start looking like something like this. It takes long. So it will take 2, 3, 4 months to get the wound to close up eventually. But if you do the wound care well, getting the sepsis out of it, alternating sometimes flamazine to betadine to have the bugs not get used to the wound as much and take the pressure off, it is doable. But you need a lot of patient cooperation, and it's quite intensive on the nursing staff. If the patients have relatives that are looking after them nicely, get them involved because they can help you a lot with that. If you don't have relatives and no nurses, you're kind of screwed because there's no real other way. You have to either then divert poo with a stoma, and some of the confused patients don't tolerate it and they end up throwing people with the poo that they can get out of the bag. And then that you'll probably not manage. But if you have very dedicated nursing teams or family, make use of them, manage these patients diligently, understand that it will take long, and then you'll actually have very good outcomes. The textbooks will always tell you that they need flaps and all of that. I will still have to find a plastic surgery service that's not overwhelmed, that can actually deal with pressure sores in our setting. So they never get flaps. They just have to be managed with chronic wound care until they eventually close and screw up by themselves. Then also a picture you've seen before, also to tell you that sometimes even fancier units get things wrong and things go not according to plan. This was a child who had electrical injury to the jaw area. We debrided it. We thought it was marvelous, and we skin grafted it straight away. And we opened the skin graft a few days later, and we were still very chuffed with ourselves. And then we opened the wound again a few days later, and the skin was gone, and it was horrible, a lot worse than this, but I don't have a picture of that anymore. And so the tedious process of dressing, washing, getting all of the sluffy stuff off it. We, in this case, actually used tongue depressors to scrape off the slough and the fat and whatever was dead and yucky in there. And did for a week daily dressings to try and get it to be clean. And it then looked like this. There's a little bit of muscle still there peeping out, but it's actually overall granulated. It wants to close. It's not gaping as much anymore, but it's still ugly and it's going to take a very long time. And we finally had theater time. So we took the child back to theater and we actually managed to close it by secondary secondary suturing, and took very well, just about no scarring. And we were able to do that because there's actually a lot of redundant skin around here, and you can pull the edges together if you undermine it a little bit. So having been chuffed with ourselves the first time around and then failed so miserably, I had a girl with electrical burns on her legs. And I thought, well, this works so well. Let's go clean those wounds, give them a bit of time, make them look similar to this, do secondary closure, and that miserably having to graft it. So none of this is foolproof. but diligent wound care will eventually get you there. And even fancier units will get it wrong at times, and you do the wrong thing for the wound. And then you must just rearrange what you're doing, how you're doing it, until you can get it to be closed. And also something that you guys will see, or I get asked about relatively frequent, is referral institute sends you back. This one had laparotomy, had wound sepsis. They are running out of beds, and this just needs wound care, so they send it back to you. Irrigate it well, scrub it if you have to, and all of the infectious, fluffy stuff will liquefy and come out. And then the wound will start looking like this. And if you keep doing it very well, it will eventually close up like this, and you don't actually have to close it with secondary suturing. It takes a long time, a month or two, or if they're very obese, even longer than that. The secret to that is similar in terms of the bed sores, is that you keep washing and you alternate the type of stuff you use. So Hibitane contains chlorhexidine. You can use betadine, which has iodine in it, and use those to wash it. Or if you have something else like Milton, use that as well, but alternate them. And then use different types of dressings. You can go from back to grass, which also contains chlorhexidine, and combine that with betadine. Or use an inodine type dressing that contains iodine and combine it with the chlorhexidine wash. Or do a silver dressing with any one of those. And that will eventually get the wound to close and pull together and scar up, and that's that. If you have a little bit of time available and something that can help you undermine the skin, and we often do it under ketamine because we don't have enough theater time, and you're left with this part of the wound and it's struggling a bit, you can clean this, same, scrub it properly, and then suture the edges of the wound together, and you hurry up the process a little bit. If you give ketamine and a bit of local anesthetic, most patients will tolerate it, even if you do it in the ward and you don't have theater. If you do have theater available, it's a lot easier to do it in theater. So then just a few things to secure dressings, because I see all sorts of things and some really, really don't work. First one, any dressing that you do, if you put a tegaderm or opside or whatever plasticky thing over a wound, or with the bandages with the wound underneath it, it will look like this. You just created the bestest breeding ground for any bugs. It's moist, it's warm, it's dark, and it doesn't evaporate, and the bugs love it, thank you, and they will grow an empire. So don't secure it with tegaderms. It will be a mess. Everywhere else on this wound, as you can see here, it's relatively dry because no tegaderm, the exudate can evaporate and it doesn't cause that manky mess. And wounds will deepen if you have a partial thickness burn and you put tegaderm over it, just because you make it septic. So what do? I tie all of them. You can see this one was tied, but then tegadermed anyway. I'm not sure why. I just tie wherever we do a dressing. If it's on a head, if it's on a thigh, if it's on an arm, tie the bandage, and then you don't have to worry about anything. Having said that, you sometimes have difficult areas, especially thighs, because what is the problem with the thigh? This area is smaller than that area. So what happens if you just put a bandage and you tie it? As they walk, the bandage will fall off because there's not enough at the top to actually keep the bandage up there. So in that case, you have to stick the bandage to the skin. Now, primal pores are even a problem at Freya Hospital, so we sometimes have only tegaderms to secure it with. Then what do? You make sure that wherever you use that tegaderm, you make sure there's no wound underneath it. If you have only a wound here, you can put the tegaderm on the anterior surface and then secure the dressing that way. Or do narrow pieces in multiple places if you have to try and keep the bandage up. Otherwise, whatever you have done is pointless because your bandage walks off the moment the person starts walking. and all the washing and all the dressing and even the fancy dressings become pointless. The same is true for the shoulder. I put this picture here because it actually gives you a lot of problems. One, shoulders are extremely difficult to bandage. They're often described to do something fancy like this. You'll all know that this will roll up and it doesn't lie like this, and it wants to open up here and it wants to open up at the top. So if you do put a bandage and you secure it like that, you still have to put primer pores over the shoulder onto the skin somewhere or onto a bandage coming from the other side to secure that. Otherwise, it will walk and you end up having exposed wounds, and bugs will get in there and dirty fingers gets in there and flies if you're very unfortunate. So shoulders, try and secure with primer pore over the shoulder so that your bandage doesn't fall off. Torso, the same. You can see the torso up here is broader than here. So if you bandage like a boob tube type of bandage and it's not a lady, it's probably going to fall off. So please secure it with a sticky on the top, and you might even need to secure it with a sticky below it so that it doesn't move around. The next problem with this one is, as you can see here, they're actually holding the bandage the wrong way around. Sorry. You should have the bandage the other way around so that you unroll the bandage over the body and not having to undo it as you go about it. Your bandaging becomes a lot easier if you change this way around and put this surface against the patient and then just roll the bandage around it. And then the last thing to securing dressings, nappies are made for bums. They're wonderful. Use them as your secondary dressing because they're absorptive, and use them to secure dressings on the bum area because they're made to go around a bum. Nothing else is made around to go a bum. If you try and bandage them and try and leave the cheeks open but cover enough, you'll get yourself just into problems, and then the patient poos or pees, and poo is under the bandage and pee is under the bandage, and it becomes one soggy, horrible mess. Rather do a nappy. It gets changed easy and it holds everything in place and can be managed that way. It does go expensive on nappies, but having to do a full bandage 2-3 times a day is also not feasible. So make use of the nappies that you have as long as you have them. If there's no nappies, good luck. You will have to then home makeshift them with towels, and that becomes very tedious, the old-fashioned cloth nappies, which is very tedious if you have to put them on an adult, but doable if there's nothing else. So having said all of these things, are there questions? I'm sure there's lots of questions. There's no way I can cover wound care in half an hour or 45 minutes or 2 hours, but I hope this helps to give an approach and to start somewhere and to figure it out from there.
Thank you very much, Helga. Are you able to see the chat?
Let me see if I can get back there.
Otherwise, there's only a couple of questions here. So the one question here is, how do you decide how often to debride or wash? But I think you answered that a little bit as you were going along.
Yeah, so to answer that one, how often to debride? You should debride once and make it clean and proper. If you keep having repeated exudate that clogs onto that, you might be using the wrong dressing, or you might have to change it more frequently or wash it more scrubbily, for lack of a better word. If a wound deepens for another reason, so burn wounds that deepen that because sepsis has gotten into it or something else, or the fat desiccated, then you might have to do it repeatedly. But I would still say you're probably using the wrong dressing on it if you have to debride repeatedly. You either did a bum job or it's the wrong dressing. How often to wash depends a little bit on the wound and what you put on as a primary dressing and a secondary dressing afterwards. Some wounds need daily washes. And if you have only Gelinet available, you might get away with alternate day washes and then dressings. If you have dressings that can absorb more exudate and are antiseptic, you might get away with once weekly dressings. And then especially that partial thickness burn wound, if you have something like Sorbact or Zeroform or Aquacel, they might be once off dressings. And you scrub once, put that on, let it dry and scab on, and then eventually it will lift as it epithelializes underneath it, and then it's a once-off dressing. I hope that answers that question.
Thank you. The next question here is acetic acid wash recommended, advised for Pseudomonas wound infections?
Yes, but acetic acid is vinegar, so it might be cheaper to buy vinegar. It does work, so does Milton. Also works quite well. If you have nothing else available, Milton, or if you have to choose between the two, I would only buy Milton and use that to treat Pseudomonas or any bug that's on the wound. Pseudomonas gets killed by Milton too.
Great. And then there's a question, when are we good to discharge a patient down referred with wound secondary intention healing, especially post-lap?
It depends on the wound. It always depends. That's the usual answer. Depending how often they need dressing changes, and are they able to come in for dressing changes, or do they need, and how much painkillers do they need for the dressing changes? So if the wound is needing alternate day care, or they can do it at home even, then they can go home and do their own wound care. If they need dressings only every 2-3 days, it might be feasible to send them home and come for dressings as outpatients. In our setting, anyone that needs a dressing more often than once a week, I need to admit we don't have the manpower to do outpatient dressings for 20 people on alternate days. So if the wound is clean and it's closing and it's manageable at home, send them home. If you need them for daily dressings because that's all you have, it's easier to keep them in the ward because there's more people around. Having said that, if you have a wound, abdominal wound especially, that is deep and now needs dressings, and the patients have their own running water at home, I often tell them, take a shower, take everything off, take the shower head and rinse the wound out properly, and then dress it, and then alternate betadine based with flamazine based, and they often do that on their own at home, and that works quite well. Or honey, if they're rich enough to buy honey, works also really well.
Great. There's a question here, can I use paraffin dressings for superficial burn wounds if they have slough, and how often?
Yes, you can use. We do if we have nothing else available. I prefer something that can eat away at the slough, but paraffin-based, so Gelonet dressings, you can use them. I would use them alternate days, and I would make sure that you wash the wound properly and try and get rid of that slough. If it's deep, thick slough because it's actually dead skin that's there, might need a debridement, might need to change it more often, but might need longer time because eventually that will liquefy and come off and become horribly and disgusting before it comes off completely. But then you're left with a granulated wound underneath it. So alternate days for paraffin dressings.
Right. And then there was a thing when you were talking about the vinegar, somebody asked just normal white vinegar, and maybe talk as well about you
Yes,
dilute
it's
that.
the cheapest one that's available. You can use that.
Great. And do you dilute it, or do you I assume you dilute it, or do you use it neat?
I would use it neat.
Okay, fair enough.
Even
And then it's a question,
acetic
yeah,
acid, use it neat. It's very weak acid, so it doesn't really do,
irritate, yeah.
but it gets rid of some other bugs.
Question here, what do you advise for burn patients being dressed for more than a year, not accepted for graft? That
Are they
question.
adults or children? If they're a child, please talk to me. If
Yeah,
they're
Angela is from
adults,
local. Angela,
yes,
do you want to unmute and just tell us whether this is adult or child?
it's an adult.
Okay. Oh, damn, shame. And then your Angela is also asking, is there a role for sugar as a dressing if one doesn't have honey? It's a bit more
Yes.
awkward applying the honey. What would be the trick in terms of applying a sugar dressing?
One of my profs as an undergrad, when I was an undergrad student, tried normal plain sugar that you buy in the shop for deep pressure wounds or these laparotomy obese people with a secondary wound sepsis. The trick to that is you need to change it as often as it looks murky. So pour the sugar in, cover it with Primopause or whatever stickies you have. You might even need to use Tegaderms and cover it. And then when it looks like it wants to get manky, it needs to be changed and then irrigated properly. And those are quite good candidates to take a shower head and rinse it off with a couple liters of water. So it does work for the deeper cavitating wounds. It's not going to work for a superficial wound. You will not get enough sugar to stay on the wound to do anything. But sugar is a conservative, which is why that prof came up with it, because jam doesn't go off. It gets maybe fungal stuff on top of it, but it doesn't go off. Bugs can't live in a lot of sugar.
Thank you.
For that adult that needed skin grafting, they still need skin grafting. Angela, talk to me. Let's see what we can come up with.
I don't think there's any hands as such. Yeah, people have just been popping their questions into the chat. Yeah, I can see this is definitely one of those really practical things, and we all have those patients that, and as you say, they're patients that you're quite often in it for the long haul, and one has to
Yes.
sort of be patient and have. It's helpful to have support and knowing if you can eventually get there if you just keep going, and that absolute dedication to doing your dressings in a regular and systematic manner. I'm not
Yeah,
seeing any.
it's a rather thankless job because it takes so long and it's a lot of effort, a lot of resources, and we often feel quite out of our depth managing them. But if managed well in terms of painkiller and sepsis and smell, you'll have a lot happier patient and you'll see how wounds actually improve with that amount of dedication. And then it's much more rewarding.
Yes, that certainly is. Great. Oh, there's a last question. Do you approach cancer wounds the same, or is there a difference?
Cancer wounds need excision of the cancer to actually close. And the other one that falls into a similar category is the venous and arterial ulcers, especially the arterial ulcers. You need proper blood supply for that wound to actually close. And sometimes that's not feasible. And then you're left with two things that need to happen. One, pain needs to be controlled. And two, the wound must remain smell free. And talk to the patient and make sure they understand this is a chronic wound. It will never go away until we actually deal with the problem that's underlying it, as in the cancer or the blood supply. And you can manage it, but they'll probably die with that wound in place. But the same principles apply. You clean it properly, get rid of the bugs because they are the ones that cause the sepsis. If there's dead stuff that wants to come off, take scissors, cut it off. And do frequent enough dressing that there's no smell and you manage the exudate that comes with it.
Great, thank you very much. Okay, and look now, couple of, would you use saline to clean and wash a wound found if soap's not available? So is saline
I would strongly motivate for soap.
okay? And you can use
When
a
I find
bar of soap you buy out of from
Milton
the.
is an option. Saline is just saline. It's just water. You can also use tap water and just irrigate it. A surgical principle is the solution to pollution is dilution. And saline does only that. It will just dilute your pollution, whereas soap actually manages the bugs. When at CMH or even at Freya, when they gave us foam bath, I threw my toys out the cot until we had proper soap in the hospital. It's not acceptable that they give us nothing but proper soap.
Great, yeah. Thank you. And then Angela's actually asking, if she can send nurses for in-reach dressing training, little Eastern Cape.
Yes, we can make a plan.
Get in touch, Angela. Some Eastern Cape love here. Very good. Thank you very much. That's pretty much perfectly on time. Thank you so much for joining us. Really, really appreciate this. Lovely to have some surgical stuff on board, and I'm hoping this is going to really make a difference out there in the districts. Have a lovely evening, everybody, and we'll see you at the next RAMP meeting in July. Thank you, and good night.
Thank you very much. All the best for all the wound cares in all the parts of the world.